of you. And wish you all a happy Dasara, happy Navratri celebrations. Amidst the pomp and show of Navratri and Dandiyas, we are here with you for an academic session. Today, on behalf of FFPAI, Dr. Pragnesh Shah, the President, and Dr. Pragnesh Vacharajani, the Honorary Secretary, I welcome you all to this first of the talks, that is first of the rheumatology series. We will be having 4 in line, one after the other, on rheumatology, where we will try to cover most of the topics of rheumatology. And if the viewers have any questions, you can post it on the chat box. I'm sure today's topic is uric acid and gout, so everyone will have many doubts. You can post it on the chat box. Just to update you all about the FFPAI activities, this is one of our activities now started. So we will have 4 sessions in rheumatology by the same speaker. After that, we are going to have some certificate courses in lifestyle diseases and many more programs. So I welcome you all. And this is to thank Dr. Pragnesh Shah, Dr. Pragnesh Vacharajani, and Dr. Mohan for bringing in AFPI, merging with us. Thank you all. Over to Dr. Manju Soneja, our speaker, Dr. Abhishek Patil. I request Dr. Manju Soneja to introduce our speaker.
Good afternoon, friends. It is a great privilege for me to introduce Dr. Abhishek Patil. Dr. Abhishek Patil is the head of Department of Rheumatology and Clinical Immunology at Manipal Hospital's Old Airport Road, Bangalore currently. He has done his MBBS from KIMS Hubli, MD Medicine from UCMS and GTB Hospital, Delhi, Rheumatology from Indraprastha Apollo Hospital, Delhi. He is the President NB Gold Medal for Rheumatology in NBE 2015. His other gold medals were his gold medal in MBBS and 18 index publications in national and international journals. Various textbooks chapters he has authored. His areas of interest are MSK, USG, reproductive immunology, and spondyloarthritis. Over to you, sir. He will be now enlightening us on hyperuricemia and gout. Is it the same or different?
Thank you. Thank you so much, ma'am, for that kind introduction. And I wholeheartedly thank FFPI for providing me this opportunity. Thank the President, Secretary, as well as Preeti ma'am for arranging all this. So I'll start sharing my screen now. Is my screen visible? No? Okay.
Got it.
1 second. Give me 1 second. Yeah, I think now it should be visible, right?
Yeah.
Yes.
Thank you. Yeah. So we'll start quickly with the hyperuricemia and gout. So this is the flow of the today's topic. We are going to learn a bit about pathophysiology, epidemiology of the gout and hyperuricemia, and how to differentiate management of these topics. So this is something which is very routinely encountered. I'm sure all the routine primary care clinics come across this very frequently, but I do see that it is something which is over-treated or misdiagnosed very often. So I would like to highlight few cases that we came across also. So this is the purine metabolism. We don't need to remember all this. This is something which we remembered in, read in our biochemistry classes, where we went say how purine metabolism leads to goes through various salts like ribose 5-phosphate, inosine, hypoxanthine. All that we need to know that the final product of the purine metabolism in humans is uric acid. The uric acid, which is something which is present in bird, which converts it to a water-soluble product called allantoin, is something which is missing in humans. So that is why uric acid is the final product of purine metabolism in humans. Now, how does this uric acid lead to gout? First of all, whenever there is a high uric acid in the body, at level of above more than 6.8 milligram per deciliter, it starts forming crystals. So it saturates in the fluid or wherever in the body, and then it starts forming the crystal. Now, when these crystals deposits in the joint, what happens is they elicit an immune response. They are engulfed by the neutrophils, which are their normal resident neutrophils or macrophages. And when these are engulfed, it leads to activation of something called NLRP inflammasome. So basically, these are molecules, proteins that are present inside the cell, which act as a conduit between any external danger signal. In this case, it is the uric acid, which acts as a danger associated molecular pattern. So we call it as DAMP. And that stimulates this inflammatory milieu production, and ultimately going through various steps such as caspase, pyrine, and others, and then finally forming one all-important cytokine called interleukin-1. Now, this interleukin-1 is the very powerful promoter of acute inflammation, generally associated with something called autoinflammatory disease. Now, you might have heard about various disorders such as familial Mediterranean fever and TNF receptor associated syndrome, a group of disorders called autoinflammatory diseases, which is distinct from autoimmune diseases such as rheumatoid arthritis. So gout is also an autoinflammatory disease. It is not an autoimmune disease. Autoinflammatory, to put into perspective, these are the disorders in which you have prominent activation of the innate immune cells, that is the macrophages and the neutrophils. So these are the main cells which are activated in autoinflammatory disorders. And unlike autoimmune disease, you do not have active participation of B and T cells. So in this whole figure, only neutrophils, macrophages, interleukin-1 beta, formation of neutrophil extracellular traps, all these are there, but there is no mention of B cells or T cells. So when there is no B cells or T cells in an immune pathology, that ultimately means that there are no autoantibodies. So unlike rheumatoid arthritis or other autoimmune disorders such as SLE, we don't have any autoantibodies for diagnosis of gout. So,
Dr. Abhishek,
yes,
please remove that Zoom part from your screen now.
I'm not able to understand what is the Zoom partner. I'm not able to see anything. Sorry. Is it obstructing the field?
Rahul, even I didn't understand.
Acha. Sorry. Yeah. Now it's removed, na?
Yes.
Sure. Thank you. Now, sorry for that interruption. So now you have epidemiology. So this is very important. Now, high uric acid, that is more than 7 milligram per deciliter, you can take it this. Various labs have different cutoffs. Actual physiological definition is more than 6.8 because beyond which there is a saturation point at which the uric acid starts forming crystals in the fluids. But
your video is off, Dr. Abhishek.
Yeah.
Now it's there, no, ma'am?
Yes.
Now, but that Zoom part has to be there then. Is video still there?
Now it's clear. Through.
No, your video is not there.
Okay. Is it okay if my video is not there? Because
it's okay.
Okay.
It's okay.
Okay. So this is very important because high uric acid, that is more than 7 milligram per deciliter, is nearly found in 25% of the adult male population between the ages of 20 to 70 years. So when you take this, a very high proportion of normal individuals will have high uric acid, but that doesn't mean that all of them have gout, or doesn't even mean that all of them require hypouricemic therapy. For example, gout, in the Western literature, they quote a figure of up to 1% of the population suffering from gout. In India, the prevalence studies are very hard to find by, but one conducted in Pune by Dr. Chopra and team found the gout to be approximately 0.1%. So only 1 in 1,000 of Indians ever experience gout. Whereas 25 out of 100, that is 250 out of 1,000 male adult population will have high uric acid. So you can understand that only 1 in 100 ever with high uric acid will develop gout. So that is why the first answer of my question, whether hyperuricemia and gout, they are definitely not same. Second, hyperuricemia, approximately 2/3 over the period of follow-up of many patients, they found that never developed any symptoms pertinent to high uric acid. They never developed any joint symptoms. And degree of hyperuricemia, however, correlate with risk of gout. Higher the uric acid, for example, if you have a uric acid more than 9 milligram per deciliter, generally you tend to have approximately 5% chance of gout, whereas the risk drops to only about 0.1% with the uric acid levels below 7 milligram per deciliter. So the degree of high uric acid definitely correlates with the risk of gout. But there are only few scenarios where hypouricemic therapy will be required apart from clinically manifest gout. We'll discuss them as we go about. And it is also important that you evaluate the causes of high uric acid thoroughly. So uric acid, as we saw in the first figure itself, is a product of purine metabolism. So there are two basic etiologies of high uric acid: either increased production or decreased secretion. So most studies quote that most of the hyperuricemic people are hyperuricemic because of decreased excretion. So you can see generally, it's not uncommon to see many families where you can see that hyperuricemia runs in families. That's because many of them may have polymorphisms in the genes which handle the uric acid excretion through renal tubules. These are called URAT transporters, which basically transports the uric acid from the lumen into the interstitium. When these are defective, they become active, and that is why you have high uric acid in many of the families, particularly. There is also one more important reason: increased production. So when you remember this, you can easily understand this table from up to date. Basically, all those disorders in which there is excess cell death or cell proliferation, say myeloproliferative disorders, lymphoproliferative disorders, even solid organ malignancies can present with high uric acid. Now, as a family physician, this is very important, because suddenly when you encounter a patient, or not even a patient, or a subject with a very high uric acid of 10, 11, do not ever jump into treating these patients, but a thorough look for understanding the underlying cause is most important, because we could be missing something such as malignancies in these patients. Now, very common causes of high uric acid that I commonly come across in clinical practice are obesity. So metabolic syndrome, as you know, one of the component of metabolic syndrome apart from hypertension, dyslipidemia, is high uric acid. So whenever there is a insulin resistance, you can have high uric acid levels. Apart from that, a plethora of drugs, including many of which I use, such as cyclosporine, tacrolimus, many commonly used antihypertensive like hydrochlorothiazide or even loop diuretics, can cause excess of uric acid production. And there are various other causes, rare causes like Lesch-Nyhan syndrome or genetic causes. I have at least not come across even one case, but these are the common things like diabetes, hypothyroidism, and drugs. All these things we need to keep in mind whenever we are dealing with high uric acid. So initial evaluation, this is the checklist which I always follow. I do a thorough physical examination, including basal metabolic BMI, body mass index. A very high body mass index of more than 30 generally portends a high uric acid. Look for drugs, particularly laxatives, antitubercular treatment, calcium inhibitors, and various forms of diuretics. All of them can lead to high uric acid. So is alcohol. So alcohol and tobacco also leads to increased uric acid because these produce insulin resistance, also increase cell turnover. So anything which leads to increased cell turnover, increased purine production, and thus result in high uric acid. This is should be accompanied by a routine checkup of complete blood count, liver functions, thyroid functions, and renal functions, because hypothyroidism, hepatic dysfunction, renal dysfunction, all of these are associated with high uric acid. As we know, CKD stages progression also is associated with increase in uric acid, because ultimately uric acid is handled by the kidney. So any failure to excrete the uric acid by the kidney tubules will result in excess of uric acid in the system. And further evaluation, though, is highly individualized. But this much basic evaluation will lead to cause in majority of our patient, particularly when the uric acid levels are between 7 to 9 milligram per deciliter. Be very careful of high uric acid. So this is one female patient. This is at the very starting of my rheumatology practice when I used to visit Manipal, Malleshwaram. This 42-year female came to me with something called vasculitic rashes. Prior to that, she had some inflammatory arthritis involving ankle joint, feet joint, persisting for 4 to 6 months. At that time, her uric acid was around 12 milligram per deciliter. 42-year female, a menstruating female having a uric acid of 12 milligram per deciliter should always ring a bell in your ears. Remember one thing in today's session, premenopausal women, gout cannot occur. So gout cannot occur in premenopausal women. So this is one thing I want you all to carry home. Gout is not almost unheard of in premenopausal women. But she was treated as gout for 4 to 6 months. All that she received is Alopurinol, and she received NSAIDs intermittently. Her pain got intermittently better, obviously because of NSAIDs. And only 1 month before presenting to me, she presented with this vasculitic rashes on lower limbs. What I could do is, when I did a physical examination, I found a large liver mass in her. And what she basically had was a hepatoma. So the hepatoma was responsible for hyperuricemia that the female had sustained for nearly 2 years. And that was a clue for underlying solid organ malignancy. And she came to me because of this vasculitic rash. We got the diagnosis, but unfortunately, always it was too late. It was too much of an advanced stage and patient did succumb. So this is one important clue that we should not miss. Another very common scenario, now this is one rare scenario, but a very common scenario that I come across very commonly in my practice is middle-aged to elderly obese males and females presenting with foot pain. Now, foot pain has itself a number of causes. It includes something called plantar fasciitis, tarsal tunnel syndrome, or TBLS, posterior dysfunction, and topifatular, various arthritis. Again, she had pain for 4 to 5 months, increased on activity, uric acid of 8.2 milligram per deciliter. So whether this patient with right heel pain, with this kind of uric acid, do you think Febuxostat or Alopurinol will help her? Probably not. When we will understand that the pain which persists for 4 to 5 months, dull, aching, present only when patient is walking, is definitely not gout. Gout is severe acute inflammatory arthritis presenting one or few joints, lower limbs, only recurring after a few years initially. To form into a continuous painful condition, it takes decades. So what this patient had was, when I put my ultrasound probe on her feet, what I did realize is that all that she had was plantar fasciitis. You can see this thickened plantar fascia in her foot, easily visible, visualized under ultrasound. And I just put a left plantar fascia also on her, just to compare the size. So what did I do is I just injected on top of the plantar fascia, and she got relief of pain. So these patients, there is no role of treating this uric acid because that is not responsible for her pain. So the typical presentation of gout is the hyperuricemia, just the increased uric acid, generally persists for 1 or 2 decades before clinically manifesting as acute gout. So painful swelling, what is called podagra, typically affecting the first metatarsal phalangeal joint of the feet. And then when such repeated episodes happen over periods of again decades or years, and it is uninterrupted and not adequately treated, then it leads to chronic tophaceous gout that are seen in this picture. So if one patient presents to with inflammatory polyarthritis of 3 months, pain, swelling everywhere in the joints, and has a high uric acid, it is not gout. Reducing that uric acid will not help. On the contrary, if you have an inflammatory polyarthritis presenting only with 3 months duration, and you have a uric acid of 10 to 12, always remember that malignancy example I gave you. You should be actively looking out for other causes. That is why high uric acid is still used as a very useful marker for many hematological malignancies. There are several things that still aid in gout. For example, this patient had this tophaceous deposit on the ear. So you can find tophi on behind the ear lobule, on the buttocks, on the olecranon bursa, and this could help you in clinching the diagnosis. The X-rays are very characteristic as shown in your figure. It shows this deep erosions in the joint. So unlike rheumatoid arthritis, these are central erosions associated with tophaceous deposits. You can see this halo here. So the tophaceous deposits, you can see around the this is soft tissue shadows around the joints. So that is gout. And also it results in, there is generally no subchondral osteopenia or sclerosis. So this is what we call this gout. So this patient had a typical gouty deposit on her left fourth PIP joint. So this is a classical X-ray picture. Sometimes when the diagnosis is very elusive, what we do is we aspirate the joint and examine under microscope, and you get this birefringent crystals, strongly negatively birefringent needle-shaped crystals. And if they are there and they're present within the polymorphonucleosides, that's also an indicating of gout. However, just finding these crystals, one-odd crystals, will be there in many normal degenerative joints. And if they are not engulfed by neutrophils, it may not be indicative of gout. So I hope I'm clear this point. Up to this point, we talked about how gout presents. It is typically a single joint arthritis affecting the lower limb joints. And it is very acute, sudden in onset, painful. And one important characteristic is it lasts just 1 to 2 weeks only. So with or without treatment, the acute episode generally subsides in 1 to 2 weeks. So if you have a foot pain and the for 3 to 4 months, which is vague, which is increased on activity, no matter how high is the uric acid, it is not equivalent to gout. So gout should have a very typical history of severe painful swelling of 1 or 2 joints, resolving in 1 or 2 weeks with or without treatment. So this is an important line. Only when such attacks persist for years together and you don't treat them, then it forms chronic tophaceous gout, where you have a persistent inflammation. Otherwise, it is not gout. So that is why it is important to differentiate high uric acid from gout. Both are quite different from each other. Now coming to management of hyperuricemia. So whether or not you treat with a urate lowering therapy, all hyperuricemia still needs to be addressed. Most important of them is smoking cessation and alcohol consumption. So if you can reduce this, you generally achieve about 0.5 to 1 milligram per deciliter drop in the uric acid. And dietary wise, this is again a very misconceived part. I see a lot of people being, advised, patients advised not to eat spinach, pulses, paneer, which is not correct. You have to avoid only foods which are in very high purine content, such as seafood or red meat. So red meat and seafood are no. But other than that, white meat, chicken, and all kinds of pulses are good. What you rather need to avoid is high fructose, corn syrup, any kind of processed food, any kind of packaged foods, because they contain a lot of preservatives, and these preservatives generally result in high uric acid. You should avoid any kind of bottled drinks, bottled carbonated beverages. Those things should be avoided. Naturally sweet fruit juices should be avoided, and generally vegetables, all kinds of vegetables, and low-fat or non-fat dairy products such as paneer and curd and buttermilk are actually good, including caffeine, to reduce the uric acid. So what generally a best way to tell about for a patient with gout is have a healthy balanced diet with a lot of proteins, vegetables, and fruits, natural fruits, not sugar mixed fruit juices that you get in cans. Generally, you should be able to control your uric acid. Now, how do you treat an acute gout? Whenever the patient first presents with acute gout, I see the first drug being started as Febuxostat or Alopurinol, which is not correct. I remember the pathophysiology I talked about, how uric acid goes into saturation, supersaturates in the fluid, and then it is engulfed by macrophages and neutrophils, and that initiates the inflammatory cascade by bringing in more amount of inflammatory cytokines and immune cells to the joint. Now, this first process of you should be to abort this attack of inflammation and not to lower the uric acid. In fact, one common problem that we encounter is during acute gout, the uric acid tends to be lower than the baseline for patient. So if the baseline patient of uric acid in the gout period, inter-attack period is say 9 milligram, it's not surprising if you find a uric acid of 7 milligram per deciliter during an acute attack, because the uric acid gets supersaturated in the joints. It's engulfed by macrophages and neutrophils. So if you give Febuxostat, in fact, you bring further reduce the uric acid, and you can further stimulate the inflammatory response. So you generally should avoid using Febuxostat or Alopurinol during an acute episode of gout. So, but if the patient is already on Febuxostat or Alopurinol, you need not interrupt the medicines. So, first thing that you should try to do is arrest this inflammation. Now, you can arrest this inflammation by using anti-inflammatory drugs. So that is NSAIDs. So that will cut off many of the prostaglandins, leukotrienes, which are produced during this inflammation. You can use steroids. As we know, steroids have broad immunosuppressive effect. They inhibit the immune cells directly or indirectly. They bring down the neutrophil numbers and then thus bring about abortion of an acute attack of gout. And what I prefer is colchicine. I tell you why I prefer colchicine, because it's quite safe, it's cardioprotective. At doses of 0.5 mg twice a day, it's highly effective. And the way colchicine acts is, it inhibits the microtubule polymerization in the immune cells and thus inhibit the neutrophil migration into the joints. So it inhibits the migration of neutrophils into the joints, and thus it is highly effective, and it also reduces the inflammasome assembly. So that is why all of that was important. I told you how uric acids deposited in the crystals within the cells, they result in this inflammasome assembly and secretion of IL-1 beta, and this polymerization of various proteins is inhibited colchicine. So colchicine is kind of a disease-modifying agent for acute gout. And one important thing is to always check renal functions, because generally GFR of 60 or less colchicine generally can be dangerous. You use reduced dose or try to avoid that and use only corticosteroids. I have one patient where nephrology team treated gout attack with colchicine. He has a dialysis patients with full dose, that too those exorbitant doses that previously used, 0.1 mg, 6 hours, and then 12 hours, and then 24 hourly. So that patient developed myopathy because of colchicine. So he developed flaccid paralysis because of the myopathy that affects because of the colchicine. So a toxic colchicine toxicities can occur, particularly in patients with renal dysfunction. So this one thing we need to be very clear of. However, the most common side effect is diarrhea. This is generally the dose-limiting side effect for colchicine. There's one more brownie point I told you. I'll talk about colchicine. Whenever you have an inflammation in a joint, and you're confused whether it is gout or some other arthritis. For example, even rheumatoid arthritis can affect the knee joint or feet joint. If you use NSAIDs or steroids, whatever arthritis, it will get better. But when you use colchicine, only if it is gout, it gets better, or any other crystal arthropathy such as CPPD. But it does not improve rheumatoid spondyloarthritis or other kind of inflammatory arthritis. So this is also a trick that I use. It's not uncommon in my practice that I get a patient with inflammatory arthritis of the ankle joint, and I'm confused whether it is spondyloarthritis or gout. It's not uncommon at all, because even spondyloarthritis can affect the similar kind of joints as gout. If the patient is HLA-B27, it is going to further complicate the matter. So what I do is I give colchicine to them. If he improves in 1 or 2 days, it's highly likely that it is gout. If it doesn't improve, then it is more likely that I should look for other inflammatory arthritis. Steroids. Steroids I also prefer, but generally I prefer giving within the joint under ultrasound guidance. So this is a MTP joint, and these crystals you can see are steroid crystals which I injected under ultrasound guidance. Oral steroids can be used varying doses. I generally prefer about 30, 20, 10 very quick taper if I have to use oral steroids. But generally, because gout is oligoarthritis or monoarthritis, I generally prefer injecting them under ultrasound guidance as shown in the picture. So I can easily get away with systemic side effect of the steroids. I will not talk too much about anakinra and others. These are other drugs which are used for treatment of gout, attack termination. IL-1 inhibitors, like they are very effective, anakinra or canakinumab, but these are unfortunately not available in India. And if you want to bring them into India, they cost something like 24 to 25 lakhs a month. So if you have to import, so generally I let go of this solution, and unfortunately I never faced anyone where I could use this kind of medication so far. So then comes when to initiate the urate lowering therapy. So one thing is termination of attack of gout. Another therapy is how to reduce the uric acid so that further attacks do not happen. So that part where urate lowering therapy such as Febuxostat or Alopurinol come into action. And generally, this is the guidelines. These are slightly different between ACR, ULR, and also now Association of Family Physicians have come up with their guidelines. But generally, most agreed criteria are more than 2 attacks in a year. So more than 2 attacks in a year, you generally initiate urate lowering therapy. So if it is very infrequent, say 1 in 5 years, you terminate the attack, make the lifestyle modifications, and probably you may not need to initiate urate lowering therapy. If the baseline uric acid, I told you during the acute attack, you will not come to know the baseline. You have to check the baseline uric acid after the termination of attack, generally after 15 to 30 days later. And if it is more than 9 milligram per deciliter as far as the ACR goes, and ULR says it is more than 8 milligram per deciliter, then also you need to initiate urate lowering therapy. Between 7 to 8 or 7 to 9, you can just consider diet modifications without using urate lowering therapy. And other comorbidities such as renal impairment. So someone with a low GFR also may benefit if you initiate urate lowering therapy at the get-go. However, there is no proof that routinely treating hyperuricemia in CKD patient is of any benefit. So this part has been proven across multiple large case cohort studies where uric acid of 8, 9, 10 is very common in those, particularly with CKD stage 4 and above. But routine initiation without gout, just treating with Febuxostat or Alopurinol may not be of great benefit in these patients. So I hope this part is clear, that when to initiate uric acid, if they had more than one attack, more than or equal to 2 attacks a year, if they are having a baseline uric acid of more than 9 milligram per deciliter, or if they have a gout attack with underlying renal dysfunction, definitely. And EULAR also states that those less than 40 years of age, you can consider starting, because they believe that disease burden is going to last for a very long time and it could lead to other potential problems. However, this is something which is an individual choice. I generally strictly follow these criteria. Then urate lowering therapy. When it comes to urate lowering therapy, there are basically 2 classes of drug. One which will reduce the uric acid, one which will increase the secretion of uric acid. Now, if I were to ask you, I told you most of our are under excretors, then ideally pathophysiologically, this should be the ideal class of drug, those which increase the uric acid excretion urine. But I'm sure that most of us won't be able to recollect even one drug which can increase the uric acid secretion unless we have read the topic in detail, because we don't usually use them. These are probenecid, benzbromarone, lesinurad. We don't use them. So we use those which are urate lowering therapies, which inhibits the xanthine oxidase, like Febuxostat, Alopurinol, and Topiroxtat, which is not, we don't have right now. And these are the 2 drugs that are our go-to drugs. And the reason is very reason is very simple, because these are simpler drugs to use and monitor. Those who are uricosuric drugs, on the other hand, have a lot of drug-to-drug interactions, and they're generally ineffective in cases of renal dysfunction. So urate lowering strategy, whenever you start treatment, you treat to target, like most of the autoimmune or autoinflammatory diseases that we start with. And generally, the target is less than 6 milligram per deciliter. So if there is no tophi, and if the target is less than 5 milligram per deciliter of uric acid, if there is a tophus. So this is the target that we generally choose for lowering the uric acid. And preferred initial choice across all the guidelines is allopurinol, that is Xyluric. We start at 100 mg per day. In patients with renal dysfunction, though, we start at much lower doses, 50 mg per day. And about fortnightly, we can check the uric acid and adjust the dose accordingly. One important aspect, whenever you start allopurinol or Febuxostat, you have to have a discussion with patient that is literally lifelong. So when you make a decision to start uric acid lowering therapy, it has to continue very long term. There are very few patients where I've been successfully able to stop the urine therapy after continuously maintaining the target despite withdrawing the drug. Unless the patients have made a drastic changes in their lifestyle, generally it is very difficult. So ACR 2020 recommends continuing urate lowering therapy continuously and indefinitely. So it cannot be that you use Febuxostat for first 1 month and then stop. Then it is of no benefit whatsoever to the patient. And another important thing which I must highlight is you must give concomitant anti-inflammatory therapy, whether it is colchicine, which is always the preferred drug, 0.5 mg twice a day, or steroids or NSAIDs for at least 3 to 6 months from the last attack. Because when you lower the uric acid, whether you use febuxostat or allopurinol, and if you do not use colchicine or other anti-inflammatory therapy, then you run the risk of recurrence of these flares. Because I told you, a crystal deposition is one thing, but precipitation of acute attack is only when there is an abrupt changes in uric acid levels. So it's very simple. You start at 50 or 100 mg of allopurinol or febuxostat at 40 mg per day, monitor uric acid 15 to 30 daily, and then continue it for a very long term. So this is the American Association of Family Physician Guidelines. This table is very nicely summarized. You can all go through this, including allopurinol. Generally, it is a first-line drug. They recommend HLA B5801 testing in Southeast Asian population, generally of Chinese. Also, technically, we are also Asians, but this has not been very well studied in our population. And the maximum target dose can be up to 800 to 900 mg per day. So this is always one of the favored drug for us because of two things. One thing, it is cheaper. Second thing, previous studies, although I'll talk about them, show improved cardiovascular benefit with allopurinol compared to febuxostat. And third thing is, it gives a huge bandwidth of dose adjustment, 100 to 800 mg. Whereas febuxostat, we limit ourselves to only 2 doses, 40 or 80 mg per day. So that is why I think we prefer this as the first choice drug. However, febuxostat can also be used, and AFP recommends that patients with cardiovascular disease or new cardiovascular event choose another alternate agent. But I'll run through two large multi-center studies, one published in NHM, Lancet. They show that this may not be required, particularly the fast trial. Probenecid we hardly use. I told you, I have so far used it only in one patient when you are not able to attain satisfactory uric acid lower levels with allopurinol, febuxostat maximum dose. You add on probenecid, but you make sure that you measure urinary uric acid, look for drug interactions, look for creatinine before initiating this drug. Pegloticase, Cristexa brand name, it is used for very bad chronic tophaceous gout. Unfortunately, this is not available in India, and this acts by, it's nothing but recombinant uricase, which converts uric acid into water-soluble products and helps in its excretion. Fortunately, this is not available in India. We have raspbericase, which is used for hyperuricemia induced by cancer chemotherapy. However, that I have used in a couple of patients. I'll come to that. Now, always the debate for us is, once you decide on urate lowering therapy, whether febuxostat or allopurinol. Previously, febuxostat was touted as more effective because it was better able to control the uric acid levels compared to allopurinol. However, we need to understand many of these initial trials limited the allopurinol doses to only about 300 mg, whereas we know that we can go up to 800 to 900 mg per day. And febuxostat, they always used that up to 80 mg per day. So dose to dose, they were not matched. So although febuxostat was believed to be more effective, further studies did not prove that. Second important consideration was renal dysfunction. It was always believed that patients with underlying renal dysfunction, maybe febuxostat is better because allopurinol can cause interstitial nephritis. However, many large studies have shown that even patients with underlying renal dysfunction, when allopurinol is used safely in doses of 50 mg and escalated, it can be used and highly effective and safe. And recent meta-analysis also shows no evidence of superiority of febuxostat over allopurinol. And one important thing that was spotted as a favor of allopurinol, which led to AFP, ACR, ULR, all recommending allopurinol as the first unanimous leader in treatment of urate lowering therapies, that it reduced the cardiovascular event by 55%, up to a dose of 300 mg per day, benefit which was not found with higher doses of alopurinol or febuxostat. However, again, the dose is highly limited. These were very heterogeneous studies, and two large trials, case trials, as you can see, showed a non-inferior of febuxostat compared to alopurinol when you use the primary endpoint of various cardiovascular morbidity in more than 6,000 patients, which was further strengthened by the FAST trial published in Lancet, which in fact shows that you can see the yellow curve. The cardiovascular morbidity associated with febuxostat may be numerically lower than alopurinol, and it did definitely achieve the non-inferiority margin. In fact, although trial was not designed for that, it is associated with lower cardiovascular risk. So dose to dose, there is no difference between these two drugs. Alopurinol is a bit cheaper, and I personally prefer febuxostat when patients have renal dysfunction. I have my biases for that because of the monitoring difficulties. Because most patients I deal with are in West Bengal, 50 to 60%. So once I start them on a drug, it is very difficult for me to monitor their creatinine and uric acid for a long term. Hence, I choose febuxostat patients with renal dysfunction, but both are equally good, and both there is no major thing to choose between them. So uricosurics, I told you, they act by increases the urinary uric acid excretion, reduces the absorption. And what the problem with these benzbromin or proboscis is, they all get filtered through your kidney, and they act via the tubules by inhibiting these urate transporters. Problem with them is whenever there is a reduced GFR, they become quite ineffective. And also there is a concern when you use uric acid excretion for long, then you probably can end up with urinary urolithiasis. So increases the chances of kidney stone formation. So whenever using probenecid, that is one practical options that we have. Make sure that you do the ultrasound screen, look for any kidney stones, and also it is definitely contraindication in proportion of patients where who are urate overproducers, for example, those who have tumor lysis syndrome or others. And always look for under drug interactions. A lot of antibiotic salicylates interact with these drugs and decreases their efficacy. And also, it may be desirable to check the 24-hour urinary uric acid and make sure that they are not, over excretors, and these can be problematic then. There is one novel drug, lesinurad, which is also an uricosuric drug, but this is FDA approved, and it acts by, again, similar mechanism as I mentioned previously, but it is very specific to URAT1. It has very minimal drug interaction, and it is quite effective even in moderate doses of moderate levels of renal dysfunction. As an add-on drug with febuxostat through crystal trials or clear trials with alopurinol, it showed us very significant, control of uric acid. As we can see, the percentage of patients achieving good low target uric acid control with whether you are using it along with alopurinol or with febuxostat, lesinurad, and that is why it is approved, FDA approved drug for gout urate lowering therapy. For some odd reason, though, the company has not released this molecule in India, and it is not available for use. Then there are various other novel drugs such as oralopinate. It is a dual-acting drug, so it acts lower uric acid by inhibiting the urate transporters, but also releases a blockade, IL-1 beta secretion. So it acts as a drug combination of, say, febuxostat plus colchicine kind of an action. So you may not need any concomitant anti-inflammatory therapy. However, again, it is only in phase 2 studies. Then rasburicase, this is one practical infusion strategy that we have. It is used very commonly by oncologists. They use it at a dose of 0.2 milligram per kg per day IV for 9 days. So most patients, it comes up to about 9 mg per day. So it comes as 1.5 mg vials. So you can put 6 of them in a 500 ml NS, and infuse it over 2 to 3 hours, and you can achieve a very rapid control with uric acid levels. But it is a drug which can be associated with hemolysis or anaphylaxis. One important point is whenever you are resorting to this is never continue the background Febuxostat or Alopurinol therapy, because it can sometimes lead to severe allergic reaction because of formation of autoantibodies. So I don't have too much of experience. I've used it in only a couple of patients, but this is a CKD patient, stage 3, and had a very poor control, which I was at even 120 mg per day. I can go up to Febuxostat 120 mg per day. This is recommended in the EMA, that is European countries do use up to 120 mg per day of Febuxostat. So despite of that and failing allopurinol, the patient continued to have severe gouty inflammatory arthritis with high uric acids of reaching more than 10 milligram per deciliter. So in this patient, I have used rasburicase, and you can see the difference that it produced. However, we were able to give only 2 infusions. Thereafter, the patient lost to follow-up, and I am unsure of the further details of this patient. So that brings me to the end of the presentation. So I want you to carry these points home. Very important, even if you forget everything. Hyperuricemia, adult males prevalence is extremely common. Gout is much, much less common. So not all hyperuricemia is gout. And all of that doesn't require urate lowering therapy. When you encounter uric acid, which is above 878 milligram per deciliter, generally think of common causes like as obesity, tobacco, alcohol, metabolic syndrome, hypothyroidism, liver dysfunction, and renal dysfunctions. These are very common causes of high uric acid. These are the ones you need to worry about. So routine checks like CBC, LFT, creatinine, thyroid, detailed drug history is very important. Quite often, many of the antihypertensives, even beta blockers, can cause hyperuricemia. So you need to get rid of them. And most patients, that would be sufficient. Gout is acute, recurrent, inflammatory monoarthritis, typically of the lower limb joints, resolving in 1 to 2 weeks. Only when you get that classical history, classical examination finding, that is an acute episode of gout, not multiple joint pains and swellings as the beginning, and high uric acid is not equal to gout. You first terminate the attack by using colchicine, intra-articular corticosteroids, NSAIDs or steroids. I prefer the drugs in that order. That's why I put them. Colchicine is my first go-to drug. Urate lowering therapy, if only if uric acid is persistently more than 8 to 9 milligram per deciliter, patient is experiencing more than 2 attacks per year, or he's having tophi. So that's one more important thing. So if he has a gouty tophi, that means that load is very high. Already the bones erosions and other things are happening. So this becomes an independent indication for treatment. Patients having kidney stones or renal dysfunctions with gout also become an indication for treatment. So with that, I conclude my presentation. I think I can stop my presentation, and I hope to take any questions.
Thank you, Dr. Abhishek. That was a wonderful presentation. You covered almost everything, and as you presented, you have clarified our doubts also. However, there are a few questions in the chat box.
Yes,
what if you don't treat hyperuricemia is one question, and attached to that, there's another question. If in case you come across patient with hyperuricemia, you mentioned about malignancy, how not to miss a patient with malignancy. So what investigations you need to do if in case you find persistent hyperuricemia. With respect to the brand name for, I think you already said it's Uric.
Yeah, no, brand names
for colchicine.
There are many of them.
For colchicine.
Yeah.
Brand name for colchicine.
Goutnil. Yeah.
Goutnil.
Yeah. Sir is correct. Goutnil is the brand name. But there are a few other companies also. And I have gotten into this habit of writing only the generic name. So brand name, even I'm not aware much. With regard to that, how not to meet malignancy, well, very high uric acid, 11, 12, always suspect malignancy if the renal and liver functions are normal. You keep looking for them, do a peripheral smear, protein electrophoresis, do a thorough physical examination. For this patient with lady with hepatoma, I just put my hands on her abdomen and liver was this big. So these are generally very promptly manifest malignancies, not hovering. So usually you will get them. You won't just do a routine cancer screen, including stool, routine chest X-ray, a basic ultrasound abdomen or a mammography. And I'm sure those malignancies, solid malignancies, which produce this kind of high uric acid will always be clinically manifest. They are not like pre-neoplastic lesions where you need to use tumor markers or other things. And hyperuricemia, what happens when you don't treat? Well, that is the question that has been answered, I mean, in the reverse manner. I mean, when you treat hyperuricemia with drugs, you are not going to get any benefits. That part has been proven. So what happens if you don't treat? You always try to understand the underlying cause. So many of cases, it is simple metabolic, so weight reduction, muscle strengthening, getting rid of usual antihypertensives that cause hyperuricemia, or stopping tobacco, alcohol, and correcting thyroid abnormalities. These are sufficient in most cases to control the hyperuricemia that is associated with the stress. And there are few genetic determined individuals, I mean predisposed individuals who have this uric acid which is higher than 8 to 9 or so, where family history is also. You just carefully observe them. Again, without gout, there is no indication to treat them unless the uric acid is about 12 or 13, 12 in females or 13 in males. When you have exhausted all your resources, you have not found a cause, and still uric acid is about 12 in females or about 13 in females, that becomes an indication from a renal protection point of view to use hypouricemic therapy. But again, this data is limited. At least I have not encountered a single patient like that, not even a single patient of that kind of uric acid. And these drugs also carry significant risk. That is what I want to highlight. Febuxostat can cause transaminitis. Alopurinol can cause transaminitis, renal dysfunction, severe allergic reaction. So when you use these medications without an indication, definitive guideline prescribed indications, so this treatment of hyperuricemia should not be used. They recommend against it. These are the words which are used by guidelines, not me. So this is used by ACR, ULR, and other guidelines. So when you use them against guidelines, then you expose yourself to litigations and other issues should something go wrong.
Sir, when
there's
should we
another
check?
Question. Sir,
Yes.
there's
Sir,
another question.
Yes, sir.
There's another question. A vegetarian male, his uric acid level, if it is 8 to 10, and there is no history of gout, is just lifestyle enough? Is the question that's asked.
Lifestyle may not be enough to get the uric acid, because generally with all lifestyle measures also, you will be able to achieve about 1 milligram per deciliter drop in uric acid. It may not be enough. It may not be enough. But seeing that, again, the same thing holds good. Try to do muscle strengthening exercise. And despite of that, if you have a normal renal functions, no cause is identified, then you can just leave these patients and observe. Do not treat it medically. Do not institute Febuxostat allopurinol. And also, I just showed you that picture, a table of up to date. There are hundreds of causes. And if you look deeply enough, generally you will find one or the other cause.
So unless and until the uric acid is very high, I think we need not have to bother too much about things like malignancy and all that. Is it right?
Yeah, I mean, you keep what I do, ma'am, if someone is having 9, 10 uric acid, is a vegetarian thin lympheno, I will look for uric acid malignancy. I will run the malignancy screening. Routine malignancy screen, which is age appropriate, maybe a stool routine, ultrasound, chest X-ray. I may not go in depth, but I will look for it. I mean, drugs have to be eliminated, obviously, all that said. And then, I mean, many of the time, beta blockers, migraine medicines, and diuretics, these are very common causes.
Dr.
So
Sanjay,
my
you can go
question,
ahead.
yeah, my question is, when should we check uric acid level? During acute attack or after recovery of acute attack?
Sir, you can get a high uric acid even during an acute attack, but generally it is about 1 to 2 milligram deciliter higher after the attack terminates. So after about 2 to 4 weeks, you will get the actual basal value of the uric acid for that patient.
And as you said that in acute attack, we should not combine NSAIDs with steroids. Is there any reason?
No, sir. I said you should not combine urate-lowering therapy generally with anti-inflammatory therapy such as steroids or NSAIDs or colchicine. Now, according to guidelines, steroid and NSAID should not be used together because of high
Gastritis.
gastrointestinal risk. That's all. And anyway, my first choice of drug is always probenecid. Sorry, colchicine, first line colchicine, because of its superior safety profile and superior cardiovascular benefit that it offers. And also, as I told you, it's a very simple hack for me to understand if it is actually a crystal arthropathy or not. Autoimmune disorders like rheumatoid spondyloarthritis generally do not respond very well to colchicine. So that's a hack that I use. When you use these steroids and painkillers, any arthritis would get better.
In a
Doctor,
patient,
carry on, doctor.
in a patient of hypertension, while we are screening, we also screen uric acid. So, what is the importance of screening uric acid? Like high uric acid, one should not give certain medicines, and certain medicines are helpful, like losartan is helpful in reducing uric acid, like that.
Yes, sir. True. Sir, converse is true. If you have a hyperuricemia, then if you are choosing antihypertensives, you may give a losartan as the preferred first choice drug. It is not class specific. It is only drug specific effect. So only losartan lowers the uric acid, not other ARBs, not other ARBs. But losartan is a weaker antihypertensive compared to telmisartan and others. So generally, you need not make your decisions only based on that. If you're able to achieve a control with losartan, you go ahead with it. And I do not screen for uric acid when I'm choosing, antihypertensives. If I have to choose antihypertensives, I will use clinidipine or losartan or beta blocker without giving too much of importance to high uric acid. So if I use a beta blocker and uric acid grows from 7 to 8, it has no major consequence to the patient, person as such. So
Similarly, thiazide type of diuretic can increase uric acid. So we should not give thiazide type of diuretic if uric acid is already high.
Yeah, that may be avoided, but also if you need that for some specific purposes, for example, treating with hypercalcemia or other metabolic abnormalities, or where 2-3 antihypertensives are to be already used and you need to use CCPs also used, ARBs used, beta blockers used, and still not achieving the target, and you still desperately need chlorothiazide, you can go ahead, even if the uric acid is high, you just monitor and you can always change. This is a practical approach. It's not clearly guideline defined, but it's not. Also, the guidelines say that one should not be dissuaded from using any medicines for various diseases such as hypertension and hyperlipidemia just because their cholesterol levels are high. Their uric acids are high.
Dr. Abhishek, one question from me. People who drink generally have the habit of drinking less water, say less than a liter. Will their uric acid be high, and increasing water consumption, will it better?
True, ma'am. That's one thing. Definitely, at least about 3 to 4 liters of water definitely reduces the uric acid. So it's one of the dietary interventions which is
recommended.
Recommended.
So 1 or 2 questions have come up in the chat box. I think Dr. Anuradha is busy. Will control of diabetes lower uric acid?
Yes, definitely. I mean, if you bring down the insulin resistance, and there are drugs to do that, I'm sure, will lower the uric acid.
And any relationship with high uric acid and CV risk? So when there is CV risk, is it necessary to treat hyperuricemia?
No, hyperuricemia should not be treated independently for cardiovascular risk. That multi-center trials have showed that treating hyperuricemia purely from reduction of cardiovascular event risk is not beneficial. So it is not to be something which we advocate, but it is a marker for high cardiovascular risk. I would say that, it's like for an inflammatory arthritis like rheumatoid, CRP is a marker. It's a marker. But bringing down CRP will not reduce your arthritis. You have to target the joints. And here also, you have to identify the risk, cardiovascular risk, and reduce that. And so lifestyle measures, alcohol cessation, tobacco cessation, and that will help you to reduce the cardiovascular risk, but not simply using Febuxostat if you leave the other risk factors unintended. So if you just reduce uric acid from 8 to 6, and if the person continues to remain, continues to smoke, it will not reduce his cardiovascular risk.
Thank you from my side.
Obesity is also one of the risk factor. Obesity.
Definitely, sir. Definitely. Obviously, all these things, anything which is a risk factor of metabolic syndrome, for which I think you are all better judges. Anything which is a risk factor for metabolic syndrome is invariably associated with high uric acid. That's why psoriasis and psoriatic arthritis have such high uric acid, because the disease itself is inherently associated with higher cardiovascular risk.
Dr. Manju,
after listening to you, sir, I think that we are over-treating hyperuricemia.
I'm not.
Because there are lots of camp being organized by different uric acid lowering agents making drugs, particularly Febuxostat. And they are having camps at our clinic, and they are saying that if uric acid is more than 9, you must start Febuxostat. But after listening to you, I think there is no need to start uric acid lowering agents immediately.
Yeah, always look for the cause, sir. The cause could be.
Yes.
Yeah. Thank you, sir, for this talk. I had a question. You said Febuxostat cannot be used in patients with cardiovascular complications. Was that the statement?
No.
I wanted a clarification.
That was the recommendation given by AFP, but that was, I think, before these two large trials, fast trials, and came up, which showed that cardiovascular risk for both Febuxostat and Alopurinol are similar. So you need not sway away from Febuxostat just because someone has a higher cardiovascular risk. It is equal to Alopurinol according to the current data. But guidelines, all the current guidelines state Alopurinol as the first choice drug in patients with cardiovascular risk.
And what is the starting dose for that? 50 mg and then up to 100?
100 in patients with normal renal dysfunction. Those who have underlying renal dysfunction start at 50.
And what about cheese and milk and all the other products? For those with borderline uric acid 6 to 8 or even above 8 to 10 in lifestyle modification, since we are not giving them medication now, restriction of all these, will it bring it in control in a vegetarian?
No, madam. Sorry, I did not catch the first part of that. What did you say? Restriction?
Cheese.
Restriction of cheese.
Dairy products.
Milk and dairy products.
No, ma'am. Low-fat dairy products are quite safe, actually.
Quite safe.
That's it. I mean, any dairy products may not be restricted for high uric acid.
Not restricted. So basically, in vegetarian, there is nothing like dairy restriction other than, I think, water. We can guide them to drink good amount of water.
Yeah. One simple way, other than the packaged foods and sweetened fruits and high fructose syrups, for vegetarian, absolutely zero restrictions.
Okay.
So if we are using, using allopurinol, starting with 100 milligram, how should we increase? By looking at the level of uric acid?
Yes. The target is below 6 milligram per deciliter. You can check it after 15 days initially and thereafter monthly. And once the target is achieved below 6 milligram per deciliter, you can maintain on that dose.
And at what interval renal function should be checked?
I generally check it at baseline, definitely. And then once I initiate these urate lowering drugs, and after that, once in 6 months is also enough.
Over to Dr. Thank you. Dr. Sanjay,
Okay.
you will do the...
Yeah. Thank you, Dr. Abhishek. You have nicely covered the topic. This topic was very burning topic in our family practice. Lots of questions were there in our mind, and you have solved most of the questions. And those who have listened to you today, I think their view for the uric acid treatment will be changed. Thank you very much, sir.
Thank you, sir.
Thank you, Dr. Abhishek. Thank you, Dr. Manju Soneja and Dr. Anuradha Paramesh for joining us. And thank you very much. It was a really enlightening talk
Yes.
on a very confusing topic.
Thank you, ma'am.
I would put it that way. Okay. So for the viewers, I have an announcement. The next webinar by Dr. Abhishek Patil again, the second of our rheumatology series, is on rheumatoid arthritis. Am I right, sir?
Yes, sir. Yes.
Yeah, so it is on rheumatoid arthritis. The next week, Tuesday, 15th of October, the same time, 4 to 5 p.m.
Sure.
So hoping that all of you will join us again. Viewers, thank you all for joining and wish all of you a very happy Dasara and Navratri celebrations.
And I thank FFPAI again for this opportunity and look forward to many further.
Sure. Thank you, sir. Thank you.
Excellent presentation, Abhishek.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Rahul, you can end the meeting.
I'll log off. Thank you, ma'am.
Thank you, Dr. Abhishek.